What are the symptoms and signs of gastroesophageal cancer? In this video, we're going to be looking at the factors that lead to the ultimate diagnosis of your gastroesophageal cancer. To review the anatomy, we have on the left here the esophagus coming through the thoracic cavity, the chest cavity, through this muscle, the diaphragm, and into the upper stomach, and the stomach lying in the upper part of the abdomen lies on top of the pancreas, that's here, and goes into the small bowel, the first part of the small bowel called the duodenum. The liver sits actually on top of the stomach. It's flipped up in this figure, and you can see the bile duct coming from the liver and entering into the small bowel duodenum, and the storage of the bile, the gallbladder here. And this bile helps to come in, digest food that is being stored in the stomach after you eat it. The stomach normally is pliable, and as you eat, the stomach will stretch and accommodate what you've eaten, and then slowly releases through the pyloric sphincter a little bit at a time to allow for digestion. Similarly, the esophagus is pliable. So as you're swallowing food, it stretches a little bit to accommodate that and let it get down. The muscles contract and help squeeze it down into the stomach, and the muscles in the wall of the stomach squeeze and contract to push the food out. So this is what's going on normally. We reviewed in the What and Where is Cancer the three major subtypes of gastroesophageal cancer, with the squamous cell esophagus being in the upper and middle part of the esophagus. Usually it can also be in the lower end. The esophagogastric junction adenocarcinomas, which are at the low end of the esophagus, the so-called type 1 Sewarts, at the actual GE junction, and at the top of the stomach, the gastric cardia, and then the gastric non-cardia adenocarcinoma, which encompasses the body of the stomach and the far end or distal end of the stomach, that is called the antrum, and then the pylorus and the pyloric sphincter. And again, I really refer to the adenocarcinomas as gastroesophageal adenocarcinoma, because as you'll see when we get to treatment, these are treated quite similarly. And also when you look at the molecular biology, when we look at that video, there's really more than one entity, but it unifies the adenocarcinomas, whereas the squamous cell cancers are quite different. Now, I should say that these distinctions, and we mentioned in the What and Where video, that these type 1, 2, 3 Sewarts of esophagus, GE junction, and cardia are somewhat artificial. There's no actual boundary that a gastroenterologist who's doing an endoscopy and coming through here can actually see. This is named after Seward, who was a surgeon who was describing, if the tumor is in this location, this is what sort of surgery you should perform. And so, that's something to keep in mind. And in fact, although we like to differentiate between these different regions, often these cancers may arise in one of these regions, but then span across them. When the endoscopist goes inside, he sees a cancer starting here, he or she sees a cancer starting here in the esophagus, and that it spans all the way down to the upper stomach in the cardia and fundus. And so where did it start? What are we calling this? A type 1, 2, or 3 Seward? They're often called the type 1 because they see it first here. But ultimately, the other thing to note is that these are pathological distinctions. So it's really at the time of surgery, when this area is removed, the pathologist can actually pinpoint, more often than not, where it actually started. Okay, so we're talking about the primary tumor, the tumor of where it initiates. And so in the GE junction here, we can see that it can be above the GE junction or below the GE junction, and we would call it a GE junction cancer. So 1 centimeter above or 2 centimeters below is referred to as a GE junction cancer, whereas if it's in the cardia, it's a type 3, or in the distal esophagus, but not near the junction, an esophageal adenocarcinoma. So when we're talking about the primary tumor, what does that mean? It really means where the cancer started or originated. So in this example, it's in the stomach here in this picture. Initially, this can be quite quiescent, and especially when it's really small, but as it grows, it can cause local and regional symptoms. And so a few semantics then to start. What is a symptom versus a sign? A symptom is an abnormality that the patient, can feel, and it can often be the heralding symptom that leads to ultimately you going to the doctor and getting the diagnosis. As opposed to a sign is really what an abnormality that a doctor can perceive or identify, often through tests like a blood test, looking and finding the sign of anemia. So some semantics there. We'll be focusing really on symptoms, but I'll show you some signs that are a consequence of the cancer and often lead to the symptoms. So an important thing to note is that symptoms can differ based on the actual tumor location, which is why we differentiate the three main subtypes of this gastroesophageal cancer. In addition to down later on, we'll learn different treatments. But first, we'll just focus that they can cause different symptoms. So looking at this figure here, where you see the upper or middle esophagus squamous cell cancer, or at the GE junction adenocarcinoma, or in the distal esophagus, or in the stomach proper in the various locations, they do have different symptoms somewhat. And so focusing first on the upper cancers, or what we would call proximal cancers in the actual esophagus or at the GE junction, some common symptoms, but not limited to this list, but the most common ones are here, is chronic heartburn, which is caused by inflammation in the esophagus, called esophagitis, and that's from chronic reflux of acid in the stomach and bile from the bile duct going into the small bowel and then backwards and retroflow into the upper part of the stomach and into the lower end of the esophagus. This can go on for decades, but it can be a sign, a symptom that you've had that you tell the physician ultimately when some of these other things start to occur. Namely, the most common one would be obstruction or blockage of the actual pipe. So when the cancer gets large enough, it will start getting stiffer in that area and also narrow the inside, or what we call the lumen of the esophagus, so that food and liquids that are coming through have problems getting through. And so this is what we call dysphagia, or food getting stuck on the way down. And the patient will report that I'm swallowing and almost immediately I'm feeling things getting stuck like in my chest, and often it has to come back up because I can't get it through. This usually starts first with solid foods, and then later, as time elapses and this narrowing gets worse and worse, even liquids can't get through. And so this is probably the most common problem that the esophagus cancers experience. Although you can have some discomfort with swallowing, which we call adynophagia. Of course, as a consequence of not being able to eat very much, or altering your diet to softer foods and liquids, you can report weight loss because you just can't eat, nausea and vomiting. The tumor can be oozing blood. It may be silent, so you don't notice it, but you can start to see black tarry stools because the blood that's being released here goes and travels through the whole GI tract and it gets absorbed a little bit and digested. And so what's left is this black coloring that a patient can report. It can be intermittent, so it's not with every stool. And so in addition to that, as a consequence of blood loss, you can get an iron deficiency anemia, which is, again, a sign. You wouldn't know that, but if you had a blood draw, it would be seen by the physician. And that, as a consequence of anemia, can cause fatigue. And then a symptom that's not that common but can occur, especially in esophageal cancers, is something that's called a fistula, where the cancer can start to invade locally and through the wall of the esophagus and into other structures like the trachea, the windpipe, or other parts of the pulmonary breathing system. And that can cause food that you're swallowing go through that fistula and into the pulmonary system and cause a number of things like coughing and shortness of breath. In contrast, because the stomach is lower down and the stomach is usually more pliable and stretchy and not as directly dependent on this one pathway, often the symptoms can occur later and more vague. And so, for example, dysphagia is not a problem. It gets through fine, and then it gets into the stomach. So After a period of time, like a delayed after eating, maybe 20, 30 minutes later, you can get a little bit of abdominal discomfort that we call dyspepsia in the stomach. Patients can note that they get full quicker, which we call early satiety. In the diffuse type gastric cancer CDH1 mutation video, we showed images of a very thick stomach. And so the stomach is no longer accommodating in that situation when you're eating. And so it's very stiff. And so you get full faster, and it starts to come back up into the G junction of the esophagus because the stomach's not stretching to accommodate your food. And so you get full a lot quicker. As a consequence of a cancer being in the stomach, you can feel nausea and vomiting, abdominal pain. Again, it's usually delayed as opposed to more immediate symptoms. When you're upper in the esophagus, you actually eat, and like seconds later, you're having the problem in the esophagus. Because of these problems, you can then get weight loss because you're having trouble eating and keeping things down. It can cause loss of appetite. Similar to the primary tumor in the esophagus, the primary tumor in the stomach can be oozing blood slowly. And so you can get black stools, which we call melena. And as a consequence, iron deficiency anemia, which can then lead to fatigue, which is being tired, weak. Also can cause shortness of breath with exertion because you don't have a lot of hemoglobin around. Again, similar to the obstruction that can occur here, usually later on, as the cancer gets a little bit more advanced, and also a delayed symptom of vomiting. So the food comes through and gets into the stomach, and then usually the obstruction is down at the end here at the pylorus, where this food is getting out into the small bowel, and so the food gets in here okay, but then as it's trying to get out, that's a delayed phenomenon. You start to get feeling of distension. It gets backflow, and then you feel nausea. So it's a little bit of a delayed symptom of vomiting due to obstruction. And then pain can be a symptom from invasion to other organs. I showed you on the previous slide the pancreas, which resides just below the stomach here. And if you get invasion of the pancreas, that can be painful, or the small bowel and large bowel, which come by above here, the stomach and below. You can get invasion directly into the bowel, and that can cause pain and also other issues like bowel movement changes. I should note that these, as I mentioned, can be heralding symptoms. So they can be things that are what bring the cancer to light. They can also be intermittent, and they can come and go. And many patients can have very few of these and very relatively asymptomatic, we would say. They can have, particularly in these esophageal cancers, just swallowing issues and none of these other things going on. On the flip side, others can have multiple things of these going on, and ultimately we lead to the diagnosis. Another thing to point out is that, of course, treatment with therapies like chemotherapy or radiation therapy or targeted therapies, immunotherapy, or combinations of those can improve each of these symptoms. And similarly, over time, say, for example, in the metastatic setting, the primary tumor can get better with this treatment. But then over time, if the treatment is stopping working, then these symptoms can reemerge. So things to be aware of. Those were all symptoms and signs that can be attributed to the primary tumor, where the cancer originated in the esophagus, G junction, or stomach. In the setting of metastatic disease, so even though the cancer starts in a certain place, eventually, if it's left in place in time and over time, silently, it can be spreading to other spots in the body. Cancer can spread via direct extension regionally in the area that it started. I mentioned how stomach cancer can invade backwards into the pancreas or the tracheoesophageal fistula. It can invade through the lymphatic system to regional lymph nodes nearby, or eventually through to distant lymph nodes. And that would be denoted here in the yellow system of pipes here that are going through the body. Common lymph nodes that it can spread to are in the supraclavicular area here, or in the periaortic and abdominal lymph nodes down here, are also known as the retroperitoneal, behind the peritoneum. In addition to, of course, the most common location would be regional lymph nodes nearby where the cancer started. And the final way that cancer can spread is through the bloodstream, which is denoted in the red piping system here. So it can be one or all of these mechanisms that it can spread. Common sites for gastroesophageal cancer to spread to are for metastatic disease, the metastatic lymph nodes that I mentioned outside of a surgical field would be called a metastatic lymph node. So surgery would go in, take out the primary tumor and regional lymph nodes. But if you have spread to these supraclavicular nodes or the retroperitoneal nodes or the perihepatic nodes, these would be considered M1 or metastatic disease outside of a surgical field. And it's a very common location for gastroesophageal cancer to spread to. Also, the liver, the peritoneal cavity through direct extension through the stomach wall, and it sort of spills into the cavity there outside of the bowel, but inside the space that's in the abdominal cavity. And we have lectures and videos all about this because it's a very common location. To the lung, particularly in the upper esophageal range, that they can spread through to the lung. The lower G junctions and the stomach, all of the blood drains directly through the liver first before coming back up to the heart. And so liver is very common in stomach and G junction and lower esophagus cancers, whereas in the upper and middle esophagus, they tend to spread directly back and then through the lung. Another common location is to the bone. The most common site in the bone would be in the vertebral bodies in the spinal column, but also can occur in the limbs, in the arms and in the legs, the pelvic bone. Uncommon metastatic sites, but they still occur and we do see it, would be to the brain, to the skin, which we would feel and you can palpate as subcutaneous nodules, to muscles and joints, a little bit less common, but can see that. Inside the bone marrow, a little bit less common, but it occurs occasionally. So different to the bone, where it's on the outside of the bone. In the bone marrow, inside the middle of the bones, where the blood is made, the blood cells are made, red blood cells, white blood cells, and platelets. It can spread into the bone marrow and displace that normal function, and you can get low blood counts as a consequence of that. Relatively rare sites for the cancer to spread to would be in women to the breast. If you have a breast mass in addition to your primary tumor of the esophagus or stomach, more often than not, that's a separate primary tumor of the breast as opposed to spread to the breast. We never say never to any of these things. We do see that occasionally, but more commonly that would be a second primary tumor. And relatively rare also to the kidneys and to the heart. Now, metastatic sites can also cause symptoms. I've been alluding to some of them. And they can be as a consequence at their particular location. So for example, in the liver, you can feel pain, right upper quadrant pain. To the bone, it can cause bone pain at that site. And also as a consequence of weakening the bone, can cause fractures there, which we call pathologic fractures. Or to the various lymph nodes that are, particularly the supraclavicular nodes, where you can palpate them and they can cause swelling and tenderness there. It can disrupt the normal function of the organ that it spreads to. Like, for example, the liver can have abnormal function. We can see that in blood tests, so it's more of a sign. The lungs, if you have multiple sites in the lungs compromising multiple areas of the lungs, you can feel shortness of breath. You can have blockages of the biliary ducts due to masses in the liver or around the bile duct where it drains from the liver. Lymph nodes that are around it that get swollen can compress the bile duct and cause a blockage. And we have dedicated video for this later. And blockages of the small bowel or large bowel as a consequence of invasion to them in the peritoneal cavity. And effusions, which is buildup of cancer cells in the fluid of an effusion. Effusions can be outside of the lungs, which we call pleural cavities or pleural effusions in the pleural cavity, and can cause shortness of breath because it's compressing from the outside in the lung. And similarly, fluid that accumulates inside of the abdominal cavity or the peritoneal cavity, which we call ascites, can cause bloating, altered bowel movements, constipation, and also discomfort and distension. And then if they're spread to the brain, which again is a little bit less common, but does occur, you can experience focal weaknesses and extremities, confusion, seizures as a consequence of a brain lesion there. And so these are examples. It's not an exhaustive list, and there's other things that could occur based on sites of where the cancer spread to. But you get the sense that each of these sites can cause symptoms as a consequence of regional problems where the cancer has spread to. In addition to that, there are sort of generalized symptoms that one can feel: fatigue or weakness and you may be mildly anemic, but not that much. But the cancer itself is secreting factors into the blood that make you feel tired and weak. Similarly, that fevers or high temperatures, which we call tumor fevers, because they're secreting hormones and factors and cytokines, we call them, into the blood, that can lead to a fever. So your physician would always be trying to track down, is there an infection? But often in the setting of where we just can't identify a known infection, we can blame it on the tumor fever. Loss of appetite, it can be, or what we call anorexia, which can lead to weight loss, dehydration, you're not drinking enough. Again, due to factors that are being secreted into the blood that just make you feel not hungry. Nausea and vomiting, not as a consequence of an obstruction of the tube or of the esophagus or stomach, but just because of these factors being released into the blood, you're feeling nauseated and even throwing up. And then exacerbation, this is an important one, because this is a strain on your body, having the cancer there can cause exacerbation of other chronic medical problems that one has, whether it's congestive heart failure or diabetes or COPD, emphysema. So this is something to be aware of, is that your actual chronic conditions can be worsening or exacerbated as a consequence of an underlying cancer. Again, some of these symptoms can be the heralding symptom that leads to the ultimate diagnosis if it wasn't really well known, and really not a lot of localized symptoms from the primary tumor. So everyone's a little bit different. And it's not uncommon for patients to present with symptoms from the metastatic site, but the primary tumor is quiescent and not causing much of a problem. Again, each of these symptoms, if we start treatment, again, whether it's chemotherapy or immunotherapy or targeted therapies, can improve. And again, can recur if and when this treatment is starting to lose its effect. Effusions, it should be noted, the collections of fluid outside the lung or inside the belly cavity, can be a little bit what we call refractory to treatment, a little stubborn, not improving much with the treatment, whereas other things, other symptoms from the cancer, like the swallowing symptoms or localized symptoms from within the stomach, can all be getting better, but the effusions persist, those fluid collections persist. And in that situation, we would be draining the fluid out, and that can help to alleviate the pressure that's being built up there. And we'll talk a lot about that in the video on palliative therapies and palliative strategies in the setting of metastatic disease. So I'm going to talk about blood clots, and because it is such a common thing in terms of symptoms from the cancer. And this is an example of what would be referred to as a paraneoplastic syndrome. So it's a problem that's occurring because of the cancer, but not in the location of where the cancer is. And it's because of factors that are being secreted into the bloodstream that are making one hypercoagulable, or in a highly clotting state. And so there's a doc century ago or two named Virchow who sort of identified a triad of factors that play a role into the risk of getting blood clots. One being immobile and blood stasis as being a risk factor for clotting, trauma or injury to the actual blood vessels, but then to have a hypercoagulable state. And in this setting here, a hypercoagulable state is from our underlying cancer and factors being secreted from the cancer, but also there are links to actual chemotherapy increasing the hypercoagulable state. And so, of course, if you have more than one of these, then your risk factors go up. And in cancer, because patients are often immobile, especially because of their condition, they're deconditioned and maybe wiped out from chemo and not moving around, there's a number of factors that play a role into ultimately getting a clot, or what we call a thrombosis. Clots occur in deep veins, or what we call deep venous thrombosis, or DVTs, and they most often occur in the lower extremities, can be in one or both. They often present in the calves, and they can be even up into the upper thigh. Less commonly, they can occur in the upper extremities and can be, in those situations, usually associated with a catheter being placed. There's a portacath, and we have a video about portacaths. So this can be related to the stasis of the blood, because of the flow is compromised, because there's a indwelling catheter in that side of where the clot would occur. Catheters can also have clotting happen right on the catheter. But the symptoms, again, of the lower extremities, which is the most common, would be calf swelling, tenderness of the calf, and or warmth and redness, which we call erythema, on that area. Many clots that are down there can be completely not symptomatic, but more often than not, eventually you will get one of these, swelling probably being the most common one, where you get what we call edema, lower extremity swelling or edema in the ankles and even the feet. And that's as a consequence that the blood is not able to flow backwards, because there's a blood clot there preventing it from being able to flow back up to your heart. The reason why we worry about blood clots in the lower extremities, or any DVT, in addition to the local symptoms that they can cause, which are not pleasant, and of course we would like to alleviate, is because pieces of that blood clot can dislodge from the lower extremity, travel up through the venous system back into the heart, and get lodged into the areas in the lung, causing problems locally there. So this is called, of course, a pulmonary embolism. And there can be a number of different symptoms. One of the more common ones would be shortness of breath, with exertion for sure, but if it's a large clot, can cause this issue even at rest. As a consequence, this can lead to low blood oxygen, which is a sign that the physician can check with a pulse oximeter. And low blood pressure, if it's a very severe and large blood clot, can actually lower your blood pressure, can cause blood flow problems and dizziness, because there's not a lot of blood getting up into your brain, can cause chest pain or discomfort, often on the side where the blood clot lodged. It can cause coughing, can cause fever, can cause a very fast heart rate, which we call tachycardia. So again, a number of these could be going on at the same time, only one of them. Sometimes they're silent and only visualized on a CAT scan, which of course is a very common thing that occurs, where at the time of restaging, we're looking to see how the cancer is doing, but the radiologist notifies us that there's an incidental blood clot in the lungs. So the treatment for these blood clots would be to use blood thinners, or what we call anticoagulants, and there's a number of common ones. Subcutaneous injection with enoxaparin or Lovenox. Enoxaparin is the generic, and in parentheses are the trade names of the drugs. There are newer oral drugs now that are pretty much go-tos, because it spares you from having to take a shot twice or once a day. There's the original blood thinner called warfarin or Coumadin, but it requires sort of tight dosing and blood draws to make sure that the levels are okay. And so in this land of cancer, we often try to avoid them. The last thing to say is that in the setting of cancer, when we do get a blood clot and we start a blood thinner, a common question is, how long do I have to be on this? And the answer usually is indefinitely, particularly in the metastatic setting, or for a long time if it was in the perioperative setting, for at least 6 to 12 months, and documentation that the blood clot has resolved before stopping. So in this video, we talked about a number of symptoms and signs that we see with gastroesophageal cancer, and that they can be heralding what leads to the diagnosis, but also can fluctuate and be intermittent throughout one's treatment journey. As the treatment is working, these symptoms can improve. As the treatment stops working, these symptoms can recur. And in next videos, we'll be looking at how we take these symptoms and what we do to make a formal diagnosis, and then go on to therapies. So stay tuned. Thank you.